about himself and what he likes to do in his, what does he like to do in his spare time?
Well, thank you, Ravi and the CPS crew for having me on. Hopefully you find this case today to be enjoyable and a lot of valuable learning. Like you said, I'm a hospitalist and associate program director. I guess outside of work, I really just like to spend time with my family, eat a lot, and travel a lot. So, and then my new project is in a couple weeks. I have a kit that I got for my birthday to brew beer at home, so I'm going to experiment with that and see how that goes.
Awesome, awesome. I also want to introduce Dr. Dancel, who's kindly going to be discussing some aspects and also the point-of-care ultrasound images. Dr. Dancel, would you kindly introduce yourself?
Sure. Thank you for having me here. I'm Ria Dancel. Please feel free to call me Ria. That's okay. I am a med-peds hospitalist and also the associate program director of the UNC med-peds program. So we take care of everyone from small to tall. And I do procedures and POCUS and things I do for fun. I like to garden. So I was commenting on the beautiful Italian cypresses behind Dr. Singh. And yesterday, my husband bought us 2 tennis rackets. So we'll see how that goes.
Awesome, awesome. I'm also going to ask Yasmin and Promise to also unmute their mics and introduce themselves. Yasmin.
Hello, everyone. My name is Yasmin Heredia. I am a medical graduate from Mexico, and I'm currently preparing for my step 1. So today I will do the teaching points with Promise.
Hi everyone, my name is Promise. I am a 3rd-year medical student. I just finished my first rotation. Now I'm on research and I'm super excited to learn about POCUS because I know that will help me for my surgery rotation and my medicine rotation in a month.
Awesome. So let's go ahead and launch the whiteboard. And Sanjay, the first aliquot, please.
All right. So we have a 44-year-old man who comes to the emergency room with a history of 3 weeks of progressive dyspnea on exertion. For about a month, has also been having a dry, non-productive cough, has been having subjective fevers, chills, night sweats, and progressive fatigue, using about 2 to 3 pillows to sleep at night for the last week or so, and also notes a decreased appetite and probable weight loss, says that his clothes are a little bit looser. Review systems otherwise unremarkable.
All right, great. I'm going to ask Ria, any ideas you have before I launch into some discussion?
Okay. This is interesting. 44 years old. For my age of 43, that doesn't seem super old. So I'm going to go with middle-aged gentleman with this sort of acute, subacute dyspnea on exertion with orthopnea. Okay, so I'm starting to think about dyspnea on exertion, orthopnea, thinking heart failure. However, the kicker here is that he has signs and symptoms of inflammation. So he's got fevers and he's also got some red flag signs that I don't love. So when folks generally have acute decompensated heart failure, we're talking weight gain, we're talking edema, and here we're talking about fevers and weight loss and night sweat. So B symptoms, and this is already becoming more ominous to me than just a straightforward heart failure exacerbation. That's my first pass thinking.
Well, absolutely right. I'm right there with you with this patient having shortness of breath. What do we really focus on here? Definitely shortness of breath, but then these associated symptoms, this exertional component makes me think, is this cardiac? I mean, with the respiratory system, we have to entertain the pulmonary plus the cardiac system. So dyspnea on exertion does ring maybe congestive heart failure, but other associated symptoms such as cough for 1 month could also associate with that. But then you can't, as in the chat, you can't help but think there could be an infectious component there, as Ria mentioned, inflammation with these constitutional symptoms, subjective fevers, chills, night sweats. But then there's sleeping on 2 to 3 pillows also makes you think about congestive heart failure, possibly orthopnea, and again, other associated features of inflammation, decreased appetite, and weight loss. One interesting thing with chronic congestive heart failure, you can get congestion buildup within the stomach and the intestinal system. So you can have loss of appetite, and that can actually be associated with congestive heart failure. So, but at this point, there's just so many things that could ring true with this, and I'm hoping there'll be some more clarity with additional features that Sanjay will provide us.
And since this is a POCUS morning report, I'm already starting to think about which parts of the body I'm going to look at along with the physical exam. And so we talked a little bit about the blue protocol, the last POCUS CP solvers that we had. So I'm already starting to think about looking at the lungs. I'm going to look at the heart. Really excellent thought about the stomach too. And so POCUS is really good for looking at fluid in the belly. And so I'll probably take a spin around there too.
Absolutely. Sanjay, next, aliquot, please.
Yeah, when I saw the patient, I was right there with you guys, with you both. There was a lot that I didn't necessarily love, and I love Ria's point, and I'm always in that mindset of what am I thinking about ultrasounding so that I can get information that will help me. So some extra information that may or may not be helpful. So past medical, past surgical history, none. Family history of diabetes, but otherwise unremarkable. No medications apart from NSAIDs, PRN. No allergies. Social history, drinks 2 to 3 beers a month, is a non-smoker, no drug use, works in construction and landscaping, lives with 3 roommates, born and raised in Peru, emigrated to the United States about 2 years ago, and goes back and forth to visit family every 6 months. On exam, blood pressure is 101/64. The heart rate is 109. Respiratory rate is 23. Tmax is 101.3 Fahrenheit. Oxygen saturation is 97% on 2 liters of nasal cannula, and his BMI is 37. General appearance, he's dyspneic in some mild respiratory distress and diaphoretic. There is no icterus or pallor or oropharyngeal lesions. It's difficult to assess whether he has a JVP due to the tachypnea and the body habitus, but no lymphadenopathy or obvious thyromegaly. Heart is tachycardic, a little bit difficult to hear the heart sounds again because of the tachypnea and a little bit of the distress. Right lung is clear to auscultation. Left base has decreased breath sounds with some faint rails and dullness to percussion. The abdomen is soft, non-tender, no obvious hepatosplenomegaly. There's mild pitting edema up to the knees, no rashes or ulcerations or clubbing on the extremities, and neurologic exam is he's alert oriented ×3 and otherwise grossly normal.
Can we go over the vital signs one more time, please?
Oh, yes. Blood pressure was 101/64. Heart rate is 109. Respiratory rate is 23. Tmax is 101.3 Fahrenheit. Oxygen saturation is 97% on 2 liters of nasal cannula. BMI was 37.
All right, great. I'll tackle the past medical history, Ria, if you want to tackle the exam, but I'll start with the past medical history. What here lends weight to some of the fantastic diagnosis being discussed, Ria, that had mentioned, and also in the chat. Diabetes mellitus definitely is a risk factor for both infectious disease, as diabetes can impair neutrophil function, so pyogenic infections can take hold. Other infections that could take hold, fungi, most likely as well. And then medications, any of these meds, just NSAIDs, could they manifest with disease in the patient? Unlikely, I don't know of anything with the lung, but with coronary vascular disease, NSAIDs can be contraindicated, especially if you have an MI. NSAIDs can impair ventricular remodeling and can result in ventricular wall rupture after an MI. Also, NSAIDs can be detrimental to kidney function. But going through the social history, there's nothing relevant here with the family history, but social history, 2 to 3 beers per month. If it was more frequent, how could alcohol manifest with illness or lend credence to some of the diagnosis or hypothesis that we discussed? Cardiomyopathy potentially could manifest with long-standing alcohol use. With infectious disease, aspiration, pneumonia could, as we know, a knee-jerk association for medical students, alcoholic pneumonias, namely Klebsiella, can be associated. Construction, landscaping, soil can be a harbinger of many different organisms, from fungi, histo, and so on, blasto, and so on. But it depends where the patient was doing construction and landscaping. Born and raised in Peru, so tropical illness can be entertained, but he had moved about more than 2 years ago. So the chat has been on fire with tuberculosis. Tuberculosis is a great mimicker and can manifest in many different ways. But I'll let Ria discuss the exam and how that would focus her POCUS imaging on
Great.
the patient.
Awesome. So on this exam, as pointed out in the chat, this gentleman is not well. He has a fever. His blood pressures are not great. I imagine for a 44-year-old gentleman with a BMI of 37, a blood pressure of 101/64 is probably too low for him. He is hypoxemic on 2 liters of oxygen, I believe you said, Sanjay, and only 97%. He's tachypnic, he's tachycardic. Contrary to maybe some people's belief, we actually do listen with stethoscope, and Sanjay listened, mostly because it helps us figure out where we're going to put the ultrasound probe. So the right lung looks fine, and I'm gonna concentrate on the left part of that heart, the left decreased breath sounds with some rails and dullness to percussion. I'm looking for consolidations. I'm looking for, we talk about what can be in the alveoli with infections, and you can actually see on ultrasound if there's pus or water in the alveoli. You can see what lung consolidation looks like, and then I'm gonna look around the lung to see if there's any effusions there. It was difficult to assess as JVD, and that's interesting. But if you really want to know what the right atrial pressure is, which is what JVD shows, I'm going to look at the heart, and I'm going to look at the IVC and the right side of the heart in particular. Someone brought up a really interesting point about Chagas disease, effusions due to TB, pericardial and pleural effusions that could be due to TB. Those are definitely things that I'm thinking about. I actually did go to Peru and saw a case of Chagas cardiomyopathy from infection sort of remotely from when this patient kind of presented to us. So absolutely, those are the things that I'm looking for.
Awesome, Ria. You're a natural at this. That was a fantastic breakdown. So I'd love to have you back on again anytime.
Yeah, I'm doing well.
Yeah. And yeah, what's interesting, I have demonstrated on rounds occasionally with ultrasound. If it's difficult enough to try and assess JVP, but with the ultrasound, you can sometimes be able to visualize it. So it can be helpful as well as the IVC, like you mentioned. But yeah, at this point, I'm still kind of going through the pulmonary exam. Yeah, definitely put the ultrasound probe on the lung and the heart and see what you find. And again, at this point, I guess the labs may help us to hone in on, could this be an infection versus could this be more likely a congestive picture? But with the vital signs and the fever, heart rate, tachycardia, and then tachypnea, although patient has a respiratory rate greater than 20, so is tachypnic, but pulse ox is holding steady. This patient is young, so they're able to compensate appropriately, but we'll move on to the labs.
Yeah, I was thinking along the same lines, and actually, if it's okay with you, here's where I was gonna, before we get to the lab, do the POCUS images. So thinking in line with Ria and Ravi, what you were saying, kind of thinking about what do you want to ultrasound and how is that going to help you?
Absolutely.
And so let me make sure that I can share my screen here. Are you all able to see that?
Yes.
Mhm.
Okay. So this is the left lung base.
Oh, pretty. Not good for the patient. It's a good image. Do you want me to
And there are lots of, just by the way, there are lots of POCUS images for this patient, but I chose to just pick a couple that I thought were the most relevant and helpful in the diagnosis.
Ravi, did you want to take this, or
I guess you could go ahead.
you want me to go ahead? Okay, so this looks to me to be a left upper quadrant, left diaphragmatic view. So Sanjay right now is pointing out a black space that is kind of to the left of this really bright curvilinear structure, and that's the diaphragm. So what he's pointing out right now is the diaphragm. Underneath that is the spleen. So to the right, I'm sorry, to the right is the spleen. Just to orient everyone, everything to the left of the screen by convention is towards the head, and everything to the right of the screen is towards the feet. And Sanjay and I have been doing POCUS long enough that he can put a probe on a body and I know what he's looking at because we all follow these same conventions. At the top of the screen is superficial, bottom of the screen is more deep. Now, why do I think that he's on the left side? Well, there's something beating on the bottom of the screen, and that's the heart. So I think we're looking at the left diaphragm, and then the space to the left of the diaphragm, so towards the head, you see a black area. And we talked about black anechoic spaces meaning fluid. Okay, so we've got fluid, and then to the left of that, or even more cephalad, we actually see part of the lung kind of flapping around. So this is a pleural effusion. Okay, and then deep to that, we see another kind of bright line with anechoic space below it. Okay, so that really bright curvilinear line that's sort of making a right angle to the diaphragm is the pericardium. Okay, so right now Sanjay is pointing out the pericardium, what I think is the pericardium, and then beneath that again is another black space. So that's another effusion. So we have what I think are two different effusions here, a left pleural effusion and a left pericardial effusion.
Yeah, absolutely.
Yeah, I agree there as well. I just want to make a note that that was a fantastic point about what's feeding there, because a lot of times the texture or the echo texture of the spleen and the liver can be similar, and a lot of learners can confuse this maybe as the right lower quadrant view versus left lower quadrant view. But you made a fantastic point there, Ria, that with the beating heart there, you would see that on the left side, and this will be the left side with the spleen there. And you're absolutely right. You have to be very systematic with this, because what really stands out is this large anechoic space. But there is another space there, so you have to be systematic and not miss the other area where fluid may be involved. But I'll pass the mic back to you, Sanjay.
Yeah, no, that's fantastic, Ria. You know, I think you talked about ultrasounding the left base of the lung. I think based on the exam, we were expecting to see this. We weren't necessarily expecting to see this space here, right? So that is certainly of concern. It's maybe a tad difficult to see, but if you watch closely with the video, there's actually a sliver of fluid right underneath the diaphragm here as well. So this is the holy grail of fluid here. We've got pleural fluid, ascites, and what looks like pericardial fluid as well. And so how that integrates into the case and how that might help. But so, you know, once we, ruined the surprise there. So knowing that we have this pericardial effusion here, you know, we were focused on the pleural fluid, but, you know, let's figure out what's going on here, because as folks mentioned in the chat, you know, the blood pressure seemed a little low, certainly is having some difficulty breathing, and, you know, looks somewhat kind of quasi unstable. And so quickly went over to the heart, and I'll hand this back over to you, Ravi and Ria.
Yeah, there's a mention of or question in the chat of where the probe is. So this is a coronal shot kind of right under the armpit, sort of in the mid axillary posterior axillary line, or the previous shot was. Now we're looking at a parasternal long axis view of the heart. Someone had mentioned that the echogenicity of the pericardial fluid was not anechoic. That's actually a fairly good point. It's hard to tell when you're talking about when you're that far away from the probe, you actually start to lose some resolution. And so it looks a little bit brighter. I agree with you. That's also probably an artifact called posterior acoustic enhancement. But whenever you see something that doesn't quite look right, and you're not sure if it's anechoic or if there's actual signal within that fluid, you're going to do exactly what Sanjay did and get a better look, a dedicated look at the heart. And so with the dedicated look at the heart, this mostly looks again to be anechoic. To me, this is a circumferential collection of fluid that's both anterior and posterior to the heart. It's kind of hard for me to pick out the different parts of the heart here, just because I don't have control over the screen. But the most anterior chamber of this heart, Sanjay, if you want to pick it out, is the right ventricular outflow tract, right there. Just below that is the septum. And so that will divide the right ventricle and the left ventricle. So the biggest cavity that we see here is the left ventricle. And then that is the left atrium that he's pointing at. I know. This is an interesting dance we're doing here, Sanjay. And then you can actually see the left ventricular outflow tract, and the aortic valve is closed right now. Okay. On the bottom of the screen, very importantly, you see the descending thoracic aorta, which we all know to keep at the bottom of our screen. So to have enough depth to that's at the bottom of the screen, because that will tell us whether the effusion that we're seeing is pericardial versus pleural. And this one, the fluid kind of tracks anterior to that descending thoracic aorta. So this is a pericardial effusion. Yeah, the big question is going to be whether there's a tamponade happening here. And so this is not necessarily the view that I would look at to assess whether there's tamponade. But we can see that the right ventricular outflow tract is doing an interesting kind of a bowing movement. And so my suspicion here is sort of, it's going to be lit up anywhere, because anytime there's a circumferential pericardial effusion, I'm going to worry about a tamponade situation. And then, you know, that bowing of that right ventricular outflow tract does not make me happy either.
Absolutely. Sanjay, what was your interpretation of this?
Yeah, excellent points again. You know, he certainly confirmed that there is a pericardial effusion. I've got a slide after this just differentiating what a pericardial and a pleural effusion can look like on this view, and based on the location of the descending aorta, as Ria pointed out. And the concerning thing here was that I hope this shows it. I tried to slow this down and get a standstill here. We've got the left ventricle here, which is in diastole and allowing blood to fill in from the left atrium into the left ventricle. But as Ria pointed out, what we have here is part of the left ventricle is actually collapsing inward. So this is a very concerning sign. This is diastolic collapse of the right ventricle in the setting of a large pericardial effusion. Is certainly extremely concerning for cardiac tamponade. And just to see how to differentiate in terms of pleural and pericardial effusions, as we see here, just like the video we had, we've got a fluid pocket here, and then we have this kind of narrowing, tapered anechoic area, and it sits above the descending aorta. That is a pericardial effusion, whereas on the right here of the screen, we see an anechoic area in the left lower portion of the screen, though we don't see that tailing of that fluid sitting above the descending aorta. and that is a pleural effusion. So on this view alone, this can help you differentiate between a pleural and pericardial effusion. One more image that I think may be helpful. Ria, you said you wanted to see the IVC.
I said I wanted to see the IVC. You know what, because in our differential, we're worried about Chagas cardiomyopathy. We also use that view to sort of get an idea of how well this heart is squeezing. And so Sanjay, you don't have to go back to it, but I think that actual squeeze looked fine. The biggest thing that struck me was the effusion, but you also want to kind of get an idea, a gestalt of how well that heart is squeezing. So I think it's squeezing fine. This is an IVC view. So at the sort of upper half of the screen, you have the liver. And then the dark anechoic tube is the IVC as it kind of flows into the right atrium. You can see the hepatic vein coming into the IVC, and that's sort of your dead giveaway that that's the IVC. And so someone had mentioned, isn't tamponade a clinical diagnosis? And so the effusion on its own doesn't necessarily mean tamponade. What you want to know is what that fluid is doing to the right-sided pressures of the heart. And you use the IVC and you use JVP to get an idea of the right atrial pressure, right-sided pressures. So what we're looking for is whether that IVC is over 2 centimeters in an adult. In children, it's a little bit different. But in an adult, are we looking, is this more than 2 centimeters? And it looks like it is, because if you look at the centimeter marks on the side of the screen, the IVC goes from about 10 centimeters to a little over 12 centimeters. So more than 2 centimeters. And then we look at how well it collapses. So with inspiration, when you breathe in, the IVC really should collapse more than 50%. And I don't think that I'm seeing that. It's a still right now, but I think when it was running, I don't think it was collapsing more than 50%. So that tells me that this is a high right atrial pressure situation.
Ria, we have a question in the chat about, isn't this a reversed orientation of the image? We see the dot to the right, so there's a cardiac view, but could you just explain that for the chat?
So the convention, there's not really a strong convention for looking at the IVC. I personally, and it looks like Sanjay likes to add the IVC onto the cardiac exam. With the cardiac exam by convention in the United States, most folks put the marker on the screen on the right side of the screen, so that when you turn the probe 90 degrees and the marker is towards the head, the heart will actually be on the right side of the screen. Now, do you have to use a cardiac convention? No, I'm not going to be mad at somebody who uses the abdominal or flipped convention. I like to do the IVC with the heart, and so I'll use the cardiology convention when I look at the IVC.
All right, Sanjay, should we move on to the labs and then discuss, I guess, Ria, we can discuss what we think may be going on then.
Mm-hmm.
Yeah, so just but before we get to the labs, and part of the reason for some of this convention was just logistical reasons, knowing that we had a patient who was quasi-unstable and findings that were concerning in the moment for tamponade. So just to let you a little bit before we get to the labs, we did call the cardiology attending and the cardiology fellow to come see the patient, and was taken down immediately to the cath lab to get a pericardiocentesis. And then into labs, about 1.1 liters of bloody fluid was drained. In terms of just general labs and testing, BMP was normal, WBC was 13,000 with 61% neutrophils. Hemoglobin was 11 with an MCV of 84. Platelets were 477,000. Liver tests were essentially normal apart from albumin of 2.9 and an LVH of 676. And an HIV test was done, which was normal. And fluid studies, just a high LDH and a high red blood cell count.
I've talked a lot. I think I'm gonna let Ravi have this part.
Sure, sure. So what here supports some of the hypotheses that we discussed here. The white count of 13,000 definitely is very suspicious, 61% neutrophils. So are we dealing with a pyogenic infection here? Not sure, but what else can we look at to support possibility of an infection causing this bloody fluid? Bloody fluid could indicate infection, but I'm very concerned about malignancy here, and especially I think Ria had or somebody in the chat had mentioned that the fluid around the pericardium wasn't essentially anechoic, but there was some almost a colloidal appearance. It was difficult to state at that point, but sometimes you can see if there's cellular debris, cellular material, if there's purulence, it can appear as a colloidal or some glittery, shimmery appearance within the fluid. The platelets of 77,000, not quite sure what's going on there. It could be also secondary. It's not a primary cause, but secondary to an infectious etiology. Then taking a glance at the chemistry, this LDH, as somebody pointed out in the chat, how do we decipher that? So going through schema, first pass would be, is this a hemolytic reaction? The hemoglobin is 11, so you can get a massive amount of LDH release with any sort of hemolysis. Second glance, looking at organic dysfunction. So we have pathology with the lung, we have pathology with the heart, liver, kidney, any of those, muscle, rhabdomyolysis can release LDH. So could there be pathology with any of those? We are dealing with the lung, so this could also help, but it doesn't really decipher what's going on in the background. And then lastly, vasculitis, lymphomas, leukemias can also elevate the LDH here. And LDH we commonly do see with medical students, we do discuss LDH elevation with PJP pneumonia, so that has a association, but it can happen with any pulmonary infection as well. HIV was normal, so that was important to get that off the table. That can also mimic many sort of pathologies. So with the POCUS imaging, I guess we don't really need an X-ray because we do know what's going on there. We have a pulmonary effusion, we have pericardial effusion, we have tamponade features. What could be causing this with blood? I'd be very, very concerned about a malignancy here. There could also be, as somebody mentioned, TB can manifest with this as well. So it's very important to at least do some of the testing for TB. And infections, I don't have infections that come to mind that could manifest with blood other than TB, but I'm going to ask Ria if there's anything that comes to mind, or if you've seen cases like this and what was the diagnosis in that case.
Yeah, someone wrote in the chat that bloody ascites is sort of a hallmark of TB, and not sure if the same for pericardial effusions. And the answer, I think, is yes. So my friends who do a lot of global health, which and Sanjay is one of them, will show big TB pericardial effusions, and they usually aren't anechoic. There's usually a lot of junk kind of in that fluid. And they're bloody and they're inflammatory. And so if I had to put a nickel down right now, this fits pretty well with TB. Of course, I think the folks that are talking about malignancy are also have a fair point.
All right, Sanjay, what did you guys find?
Yeah, great points. And I will confirm what Ria was saying about the bloody effusions are fairly characteristic for tuberculous pericardial effusions, and the lack of fibrinous stranding and pericardial thickness and increased echogenicity probably speaks to more of a acute/subacute process versus a more chronic process in TB, where you can get TB pericarditis and TB myopericarditis and constrictive pericarditis. So, one great thoughts, and, we're thinking along the same lines. So just to investigate the pericardial fluid a little bit more, AFB cultures were sent from that, which were unremarkable. We're also thinking about malignancy, so both the cytology and flow cytometry were sent, which were also unremarkable. And we know that we had another fluid space, so we were trying to see if we could compare the two, and you know, are there two things going on, or is it essentially the same thing? So we did end up tapping the pleural fluid, and the pleural fluid was exudative, high LDH, high protein, also dark red, bloody, very similar in characteristic to the pericardial fluid. And AFB and cytology and flow cytometry were also sent from that fluid, and those were also unremarkable. Anything else you want? I see a question in the chat, which I was hoping that we would get to, but it was ADA level sent on the pleural effusion. It was also sent in the pericardial fluid, and they were both not elevated.
That's interesting. That's a sort of discarded our primary hypothesis, secondary hypothesis with the malignancy. Then connective tissue disease is kind of very suspicious here and can be entertained. So I would ask for any testing, ANA that was done and sent off.
Yeah, ANA and an ANCA were both done, and a rheumatoid factor, and all of those were also unremarkable.
With connective tissue diseases, you know, we see a fair bit of pleural and pericardial effusions with lupus, for example, and those look serous. They're not generally bloody. Someone asked how we can differentiate between a traumatic tap and a bloody effusion in low volume taps. So traumatic taps, if they're bloody enough, will typically clot. If the blood has been there for however long this has been going on, 3 weeks or so, it will look bloody, but it won't clot. So these are sort of blood products that we're talking about. And I have to say, I don't know what fungal disease would look like. So if he has effusions due to fungal diseases, that's a gap in my knowledge. I don't know if that would be bloody.
Yeah, I don't also have experience with the fungal diseases causing such presentation, but yeah, I would run the whole gamut of histoplasmosis and blastomycosis and so on, and see if that, basically I would send off a 1,3 BPG and see what doesn't it cover. Muco or crypto would be the ones that it wouldn't test for, but that would just sort of be a ANA of fungal diseases. And there was a great point in the chat. Does Chagas manifest with bloody effusions like this? I don't know, but that would be something to also explore. If I have a gap in knowledge with that, definitely I would look at that as well.
Can it be a Coxsackie virus? So, you know, with Chagas and Coxsackie viruses, I think of those as causing more of a cardiomyopathy than I would with effusion. So I would look to see if the heart is dilated, if it's not functioning well. But I don't typically think of those things as causing big effusions.
And they would typically cause a transudative, not a bloody effusion.
Yeah, so
what do you
just
think?
Some more information. Yeah, some more information. Excellent points about the looking at the heart function, particularly post drainage. So a TTE was done after the fluid was drained, and the LV function looked to be preserved. There were no issues with the right ventricle, so otherwise a relatively normal myocardium. And then somebody actually put in the chat, I think I saw a little bit up there, about hunting in the chest for something else. Is this possibly a malignancy? Though TB can notoriously be AFB negative over and over and over again, and certainly hails from an endemic area, so certainly always number 1, 2, 3, and 4 on the list of differential diagnosis. So a CT chest was done eventually to just report the residual left pleural effusion, residual pericardial effusion. There were multiple mediastinal and hilar lymph nodes, none larger than 1.5 to 2 centimeter, and some scattered nodules in the left upper lobe, left lower lobe, right middle lobe, and some pleural thickening. And so then, we're looking at time here. So we did send, just to let you know a little bit about what happened with the patient, presumptively with knowing that all of these tests were negative, but epidemiologically speaking, was empirically treated with RIPE therapy, but did not improve over the course of about 10 days and had a complicated intensive care unit stay, developing respiratory failure, needing to be intubated, had ventilator-associated pneumonia, developing an AKI requiring hemodialysis. But the team there said, let's send this fluid again for cytology. And so it was sent a second time and it was unremarkable. And then it was sent a third time and revealed what the final diagnosis was, which was non-small cell lung cancer. Unfortunately, the patient passed away shortly thereafter.
I'm sorry to hear that. He's so young.
Yes, very much. Unfortunate case, very good learning exercise. But I think, you know, when you think about when you think about tamponades and non-traumatic or non-iatrogenic tamponade, I think TB, malignancy, and autoimmune disease are your 1, 2, and 3 epidemiologically speaking, and each in its own right very difficult to diagnose.
That's I was gonna put my nickel down on TB over and over again, even with the negative tests, just because
mostly everybody did.
it just happens where you don't actually get you don't get it in culture until the second or third time you send it off. Same's true for cancer cells also.
Yeah, I was going to add a fantastic case, and yeah, I was right there with the chat. Ria, you did a fantastic job. That was incredible. It was great to co-discuss with you. You're on fire with all the different differentials.
Thanks. That's such a great case, Sanjay, and thank you, Ravi.
I see one comment in the chat, which I do want to make sure is verbalized to everybody, that Rebecca put in there. Such an important lesson about the low yield of fluid cytology, particularly pleural fluid. Ria, you know this as a fellow proceduralist. If you really have a high suspicion and no plausible alternative diagnosis, keep sending it over and over again.
Right.
The more you send it, the higher the yield is going to be of hopefully eventually finding out what's going on.
Yeah, I was going to add, I got cut off, sorry. The lymph nodes on the CT definitely stood out to me, and those, maybe by doing a transbronchial needle aspiration, could have gone the diagnosis. But with so much happening there, Sanjay, it's just very difficult to prioritize that, and while you're having the patient go through many different complications. But absolutely fantastic case. Definitely, I like that differential with bloody fluid, TB, malignancy, and autoimmune disease, prioritizing those, and very difficult getting the diagnosis. I really want to give kudos to the team for repeatedly sending off the cytology to try and get the diagnosis. Any other reflections, Ria, before we go through teaching points?
No, it's such a good case of bloody effusion sort of everywhere, and very, very good differential diagnosis for that, which is, it's pretty narrow, honestly. But you know, as a proceduralist, Sanjay's also a proceduralist. When we see bloody fluid, that sets off alarm bells, and there's not a lot that will do that. Someone had asked about draining a pericardial effusion and whether you have to do it slowly, or if there's a limit in draining a pericardial effusion. I don't think that there is, honestly. You obviously want to drain them until they are hemodynamically well. I also don't limit how much I take off when I do a pleural effusion. When I tap a pleural effusion, Sanjay may have more experience with those, with a pericardial effusion especially.
Unfortunately, I don't do enough of those, so I don't know. I left that to the cardiology team, but they seem to drain all of it at once and left a tube in.
Mhm.
Sanjay, I just want to highlight those incredible POCUS images. Those are great, especially the first one. It's very easy for a lot of the audience and learners to be able to obtain that view. So admitting a patient in the emergency room, just using the probe and getting a quick answer to one of the differentials you have for dyspnea, pleural effusion, and ruling that out. And I didn't even expect to see a pericardial effusion at that time, but also attention to the heart to see if there's fluid around that. So fantastic images. We'll have Yasmin go through the teaching points to wrap it up. Yasmin.
Hello, everyone. Yes, this was an amazing case. So for the teaching points, our red flags that we started talking about were the fever, the weight loss, night sweats in this patient. And we started thinking about these cardiac causes of dyspnea. We started thinking about maybe this was a heart failure. And of course, think about if it was left heart failure, right heart failure. And Dr. Ria talk about the blue protocol. And if I'm wrong, please correct me. The anterior lung sliding is checked first. It excludes pneumothorax. The P profile suggests pulmonary edema. The A profile prompts a search for venous thrombosis. The presence of lung profile and venous thrombosis equals a pulmonary embolism as the cause of acute dyspnea as the top of the diagnosis list. Of course, by that time, the chat decanted towards a infectious cause. And then we started watching the POCUS, all these images, these amazing images with the probe around the mid-axillary posterior axillary line at the left side and the marker on the probe towards the head. And we watched a pleural effusion plus a pericardial effusion and ascites. And we started thinking about what could it be, the main causes of this bloody pericardial fluid. Could be post-cardiac surgery, cardiac rupture, aortic dissection. Of course, we were thinking about tuberculosis and malignancy. In this particular case, malignant pericardial effusions are more commonly caused by metastatic disease, in particular lymphomas, leukemias, melanoma, lung cancer, breast cancers, rather than primary malignancies. Malignant pleural effusions are the accumulations of exudative fluid and malignant cells in the pleural cavity, and it's due to the cancer-related barrier dysfunction of the capillary walls, causing an increased permeation of plasma protein, blood cells, and the tumor cells. And in our last diagnosis was a non-small cell lung cancer, which is roughly the 85% of lung cancer, and it includes lung adenocarcinoma, squamous cell carcinoma, and large cell carcinoma of the lung. This last one has a strong association with smoking, has a poor response to chemotherapy, it metastasis early, and has a really poor prognosis. So it is often managed surgically with or without chemotherapy. And well, those will be all teaching points, and I hope you like them. And thank you again to Dr. Sanjay for this amazing case, and Dr. Ria, you were amazing discussing, and thank you all.
Great job, Yasmin. Thank you for the teaching points. And again, I really appreciate Sanjay and Ria for coming on and giving us some fantastic POCUS education. You're really helping us push this initiative forward here on Clinical Problem Solvers. So don't forget to come back again and visit us and maybe co-facilitate in on the other sessions that we'll have during this month. So appreciate it again. Take care, everybody. Have a great Tuesday.